Good evening, Dr. John.
Hey, how you doing, Jitin? Welcome. We start in about 15 minutes.
Yes.
Okay.
Yes.
Good evening, Jitin. Good evening, Dr. John.
Hey, how you doing?
Good evening.
Oh, okay. Well, I'm sorry. That's the recording.
Good evening, Parihar sir.
हाँ, गुड इवनिंग जितिन। आवाज आ रही?
Yes, sir. Good evening, sir.
Good evening.
गुड इवनिंग सर।
Parihar, good evening, Jitin.
Good evening, sir.
Good evening, sir.
All well. I think same way we will be doing. I mean, presentation first. I think Dr. John will introduce Jitin. Okay, and then Jitin will introduce all of us, and then we start things. So after that, my presentation, everybody, all panelists will have, their comments, and then we'll address question answer session. Okay, so can I see my whether the video is running very well or not?
Yes, sir, please.
Yeah, hold on, let me come in there, you know.
Okay.
Good day, how are you doing today?
Good day, good day. I am fine. Regarding next webinar, there may be some issue. I am forced to go and inaugurate the young neurosurgeon conference at Hyderabad. So the proposed flight for Jabalpur, it is 7:10. So I don't know, from airport to my place, sometimes the flight also get delayed in India.
Yeah,
So
everywhere in the world that happens.
Yeah, so can we do something? Maybe there are two options. One is that one of my colleague will speak for some time in the beginning, and then I complete my talk, or we can delay it. I think by 8:30 I should be at home.
Okay, what day is this? Which session?
It is 11th of June, next webinar.
Next webinar, so you want to change it because you're not able to get to it.
Yeah, I think 8:30 I should be able to come. I'll
Okay,
be like,
we can make contingency plans.
okay.
Yeah,
Okay.
that if you're not there, then someone fills your spot and essentially presents what you were going to present.
Yeah, the other panelist may present his or her experience for some time, 10, 15, or maybe some time, half an hour. And by that time, in case I don't reach, usually I think it should be possible for me to come by 8 o'clock. So
Well,
can
we can delay it an hour if you want to start at
Yeah,
9.
I think-
We
Yeah,
can
9
delay it at 9.
is safe, no problem. Then I'll be able
Yeah,
to.
we could change it to 9 to make it more possible that you're there.
Okay.
Yeah.
Okay. Thank you.
Okay,
So,
and even then we'll make contingency plans, because you never know at airports.
yeah, correct. So is it, can I share my video?
Yeah, go ahead. We have 6 minutes.
No,
And welcome everyone else.
Yeah, all panelists, we have Dr.
We have everybody there.
Yeah, everyone.
Good evening, sir. Good evening, John.
Okay, now, good evening. Now I introduce Jitin. You're moderating today?
Yes.
Okay,
So-
I'll introduce Jitin first, and then he runs the show essentially.
Jitin is associate professor at the place where I am working, Jabalpur. And his interest is endoscopy plus functional neurosurgery. He does a lot of functional neurosurgery, including epilepsy surgery.
Okay, where are you from, Jitin? What city? Oh, you're from the same city as Dr. Yadav.
Same city.
Yes.
Jabal.
Same, Jabalpur.
Pretty soon I got to know the geography of India. Slowly. It's such a huge country, just like America.
Yeah, but we are in the exactly central place of India. Just center.
Oh, really? The center of the country?
Yeah.
Is that a like a bragging point of the city? We're the center of the country and everything.
So I can.
Yeah,
if
you want? Yeah, let's test it. Go ahead. Go ahead.
Quality of images are okay.
Yeah, the images are fine.
Yeah, this is what I wanted to see.
Okay. There's no video, right? No audio, no sound, right?
No audio. I'll be
Okay.
speaking. Yeah.
Yeah, it's working fine. It looks okay.
The colored picture also.
Yeah,
Yes.
that's color.
Okay. So I think it is fine. Okay. All right. So I stop share. Dr. Kodai, John sir, he is also doing a lot of good work. And Professor Vijay Parihar has recently. Hello.
Yes, sir. Yes, sir. Listening.
I think John must have been doing some other work. So we should congratulate Vijay. He has been promoted and as professor, and also
Yes, sir.
Shailendra Atre, both. So
Congratulations,
congratulations.
Parihar and Yadav.
Thank you, sir. Thank you. Thank you.
In Jabalpur itself?
Yes, same place.
Yes, sir. Yes, sir.
They are, I mean, they have been helping me along with Jitin and other colleague,
Yes, sir.
medical college. I think you know this Kodai, I have retired.
Yes, sir.
Yeah.
So now you are not in the government setup, sir. You're only in private setup.
Yes, only in private, yeah.
Oh.
Hmm.
Then you can visit us on and off for teaching us.
Yes, why not? Yes.
Yes, sir. So I'm planning to create a Jabalpur model in Chennai, sir.
Excellent. Good. You gave me some ideas about breaking of the spinous
Yes,
process,
sir. Yes.
which I am using, but I have not taken your patent. I mean, I'm
No,
not.
sir. No, sir. No, sir.
I break the spinous process for bilateral decompression when sometimes the spinous process is very thick, and
Yes,
do the bilateral decompression.
Yes, sir. We started doing endoscopic subdural hematomas and ICH evacuation in my hospital, sir.
Excellent.
My boys started doing actually after your series of lectures, my boys started doing these two procedures in recent time. So slowly we are converting all procedures into endoscopic.
Okay, excellent. I think it is 8 o'clock now.
Okay, are you ready, Dr. Yadav?
Yes, yes.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. This is Dr. John Bennett, broadcasting our a weekly series of neuroendoscopy by Y.R. Yadav, a neurosurgeon that's the head of the Neurological Society of India. And he's on episode 9. And I'd like to introduce Jitin Bajaj. He's a neurosurgeon from the same hospital as Dr. Yadav in Jabalpur. And we'll let him run the show. Welcome, Jitin.
Thank you very much, Professor John. Greetings, respected faculty and colleagues around the world. Hope you are all fine. Today is the 9th webinar of India Neuroendoscopy series being given by Professor Y.R. Yadav. And the topic is endoscopic interlaminar lumbar discectomy. Professor Yadav sir is the current president of Neurological Society of India and past president of Neuroendoscopic Society of India. He has more than 350 publications with more than 10,000 citations. He has also written a book on neuroendoscopy titled Neuroendoscopic Surgery, a Comprehensive Approach, and I think we all should read that. Thank you, sir, for agreeing to deliver today's talk. Today, we have with us 3 expert neuroendoscopic surgeons as esteemed panelists. Professor Kodiswaran M. is the current head of department at Kilpauk Medical College, Chennai. Professor Vijay Parihar and Professor Shailen Ratre are senior professors at NSCP Medical College, Jabalpur. All of them have extensive experience in endoscopic management of lumbar disc and have written prolifically on this topic. Thank you very much for agreeing as panelists. Last but not least, we thank Dr. John Bennett for organizing these events. Without much ado, I request Yadav sir to begin his talk.
Thank you, Jitin. I think I share my screen. Is this
Yes, perfect.
available? Yeah. So today I'll be talking about endoscopic interlaminar lumbar disc surgery. Greetings from Jabalpur. It's a central part of India. Nothing to declare. The lumbar disc surgery, these are quite common, and majority of them can be managed by conservative treatment. But if the conservative treatment fails, or there is a progressive neurodeficit, or there is a neurodeficit, in that case, we should go for surgery. So how long conservative treatment should be given? There is little bit of controversy, but 2 to 3 weeks of conservative treatment is enough. So if the pain is not managed by conservative treatment of 2 to 3 weeks, then you are justified to operate. Or if this pain is so severe and the patient demands surgery, and there is a compression corresponding to the pain, radicular pain and low back pain, then also you can do surgery. But if there is a deficit, neurodeficit, it's a definite indication for surgery. The endoscopic approach, as you all know, initially was advised for unilateral symptoms and for only one level disc, but now bilateral symptoms and even multiple level disc also can be operated. So you can have unilateral symptoms or bilateral symptoms, single level disc or multiple level disc, but I do it only up to 2 levels, 3 level or more because it takes more time. So I don't do 3 level or more than 3 level endoscopically. I do it with microscopically, but I go from one side and do almost the same thing what the endoscope, preserve the opposite side lamina and do the decompression. It can be done for highly migrated disc. Initially, it was not advised, but now it can be done very well. especially with the interlaminar approach, can be done for lateral disc, central disc, or recurrent disc also. And even if the disc is calcified or fibrous, you can take them out. You can use osteotome, you can use rongers. So anything which is possible by microscope also can be done by endoscope now, the way, and I'll be discussing that. And it is possible at all level from L1 to L2 to L5S1, which sometimes is difficult for transforaminal approach. And this is possible for lumbar canal stenosis, including very severe canal stenosis, which may comprise of not only the disc, but you can also have the ligamentum flavum hypertrophy, the facet hypertrophy, the foraminal stenosis, all of which can be addressed using interlaminar approach. If you have extraforaminal disc, then it is not advisable to go interlaminar. It is better that you go in between two transverse process and take that extraforaminal disc fragment. The approach is almost same, but you remain lateral to the facet joint in between the two transverse process. The contraindications are the unstable spine, because if there is an unstable spine, you should decompress and fuse also. And relative contraindications are 3 level or more. It takes more time, although the decompression can be done at multiple level. Very important thing that there should be good clinical and radiological correlation. Sometimes radiology look very extensive. So you may find 3-4 levels, but the patient symptoms are of 1 or 2 level. So good clinical and radiological correlation is a must. And you must study the MR and CT scan sometime. Also, CT is also required. The investigation of choice is MRI. But for bony details, if you want to see, then you might need CT scan. So what is important before surgery for you to see in MRI or in CT scan is that you should see the status of a spinous process. Sometimes the spinous process are angled. See, if the disc is on this side, okay, and if the spinous process is also tilted on that side, this tilted spinous process will not allow tubular retractor to be placed properly. So that you should know, and if it is there, you can drill this tilted spinous process, or sometimes the spinous process may be very hypertrophied. So hypertrophied spinous process also will push your tubular retractor laterally and will not allow the proper docking of your tubular retractor here. Or if you want to go for docking, it will be angulated medially like this. And then it will be difficult to do decompression on ipsilateral side, and the foraminal stenosis on ipsilateral side will be difficult without damaging the facet joint on ipsilateral side. So if it is there, it is better to shave off some of the spinous process, or tilted spinous process also can be drilled. So if it is tilted, curved, or bulky, then it is better to drill that part to allow the orthogonal placement of your tubular retractor there. Then next thing which you should see that the lamina. The lamina may be horizontal like this. See, so placing a tubular retractor here will be easy, but there may be lamina which is vertical or oblique like this. It usually happens in upper lumbar regions L1, L2, L2, L3. At that level, usually the laminas are vertical rather than horizontal. So there will be problem in station of tubular retractor there. So if the lamina is vertical or oblique, it is better that in the beginning you shave off little bit of the lamina, the outer table of the lamina, to allow your tubular retractor to be placed properly. Otherwise, again, if there is no facet hypertrophy, the one outer part of the tubular retractor is here, the another will be here. So you will be having a tubular retractor placed like this. So working on the opposite side will be all right, sorry, but working on ipsilateral side will be difficult. So if it is there, it is better to drill in the beginning and place the tubular retractor orthogonally. It is important. I don't like the working channel to be placed at too much angle. It may be 10 degree, 20 degree, or little bit of angle. But if you have too much of angulation of your tubular retractor, the working will be difficult. So try and make things simple. Drill the spinous process if it is bulky or curved or vertical. Lamina can be drilled to place the tubular retractor correctly. Then you should know what is the interlaminar window, which I'll be discussing in the next slide, because that is also very important. If there is a narrow interlaminar window, it may be difficult to work with the Carrison punch without drilling. And you should also know the facet joint. At times there is a facet hypertrophy, huge hypertrophy. So your tubular retractor is far away from the area of interest, that is from the lamina. So find out how much hypertrophy is there. That also need to be tackled. So these things may create difficulty in for a beginner. Then you should also know the location of the prolapse disc, whether it is central, whether it is lateral, it is foraminal, or it is migrated up or down, because you have to take it out, and you have to choose approach accordingly. Then you also must know whether the disc is soft, fibrous, or hard, and if there's any osteophyte, and what is the location of the root, whether the root is pushed medially, laterally, or posteriorly. The most dangerous part is when there is a disc fragment which is pushing the disc root posteriorly and it is lying against the lamina. And if you try to take out the lamina by Carrison punch, you may injure the root or the dura and cause CSF leak. So make sure that what is the location of these dura and the root, and whether there is associated ligamentum flavum hypertrophy. So study MRI carefully and then plan things. This is the interlaminar distance. This interlaminar window is measured by the horizontal line, that is the red line, between the lateral edge of the spinous process. So this is the spinous process, lateral edge, and the medial margin of the facet joint. So medial margin of the inferior facet. So this is the line that you should see, and also you should be able to see how much is the distance between the inferior margin of the superior lamina and the superior margin of the inferior lamina. Sometimes there is hardly any space available because of the hypertrophy or because of the upper location in the upper lumbar region. So in that case, you have to drill first to create that window and then use Carrison punch. This is what I was talking. You should know what are the different type of the disc prolapse. It may be shoulder type, it may be axillary type. When it is axillary type, it usually the disc fragment touches the lamina or the ligamentum flavum. So this is known as kissing sign. So if you see a disc material just opposite the lamina or the ligamentum flavum, usually it is the axillary type of the disc. Whereas if it is shoulder type, then it pushes the fragment, the root medially, and it is usually in relation to the superior articular facet. The most important and most dangerous is the central type of the disc, which pushes the root. When it is anterior to the root, so this will be pushing the root posteriorly, and such patients are at risk of root injury or even the dural tear along with the CSF leak. So what type of the disc is there? If it is ventral type of the disc, ventral to the root, then it will be pushing the root anteriorly, and it is sometimes it is lying just opposite to the lamina, and if you try to take a bite, you may also injure the root and cause CSF leak. Then you should also know what are the different positions of the disc prolapse. It may be just against the disc, which is quite simple. So in every case, so against the disc prolapse, against the space of the disc, but it may be higher up in the superior part of the transverse process. So zone 1, this is zone 2. Zone 3 is from the upper end of the inferior vertebral body to the middle part of the pedicle, and then zone 4 is the inferior part of the pedicle. So these zone 1, zone 3, and zone 4 are difficult in the transforaminal approach, but it's not difficult in interlaminar approach, because in transforaminal approach, you are coming from here, and then you can work around it. Although they have now curved forceps, and the experienced endoscopic surgeon can also remove them. But high migrated discs are difficult to be removed by transforaminal approach. Sorry. Regarding the procedure, the patient is prone, and you should use the radiolucent table because you require C-arm for localization, generally done under the general anesthesia, but you can also use a local anesthesia. So various positions are possible. You can break the table, you can use bolsters, one placed against the chest and another below the hip joint here, or you can have also vertically placed bolsters, and so that the surgery becomes easy. Some people use knee chest position also. It allows better opening of the interlaminar window, but I think it is not physiological. You may get a wrong idea of that you have done a good decompression, whereas if it is in the neutral position, it gives you a good idea about the amount of decompression. But this also works very well. People use it quite effectively. I use bolster on the side. So various endoscopic sets are available. You can use Dest Endoset, you can use EasyGo. There are other systems available from other companies. They are also equally good. So the first thing is the proper localization. You know, in endoscopic surgery, the localization, the incision is small, therefore you have to be dot at the place where the disease is, that means the disc is. So you go for localization, and there are commercially localizers available by the various companies. This localizer also can be moved in cranial caudal. It can be angulated to the side. The two arm can be rotated. The left side may be moved up, or right side may be moved up, or these may be tilted cranially or caudal. Three cardinal movements are possible, but you can also use LP needle. But if you use these localizers, make sure that both arms of the localizer should superimpose. If one arm is seen only, then one arm may be here at maybe L3, L3-4 level, another may be at L4-5 level. So both cannot be correct. So both the arm should superimpose when you use these two arm localizers. This is important. And at times, what I advise is that your localizer pin should be at about 90 degree from the surface. If these are bent cranially, caudally too much, then your skin incision is at a different level, and the disc is either cranially or caudally. So you have to go for too much of angulation, which is not correct. So what I do, if there is an excessive lordosis, so this is an example. This is L5S1 disc. And if you want to remove this L5S1 disc, then your incision has to be placed much more cranially. So to reach that, you have to go at the center of the disc. If you make the incision at the same level where the disc is lying vertically, in that case, you will not be able to go in the disc space, and it will be striking at the vertebral body here. So the disc removal will not be possible. So avoid excessive angulation of your tubular retractor. If there is too much of lordosis, then you break the table. So make this lordosis into the flat spine, and then once you make this spine flat, then your disc level and the incision will also be at the same. And I told you, it is always far better to be orthogonal. That means your tubular retractor should be around 90 degree to the area of your interest. So in this surgery, mark the midline, mark the level of the pathology as shown here. So this is the midline we have marked, and this was the level where the disc was there. So the incision should be about 1 to 1.5 centimeter away from the midline. So mark the midline, mark the level, and then you mark the incision about 1 centimeter away from midline. So small incision is given, which is about 1.5 to 2 centimeter, and it is about 1 centimeter lateral to the spine. And that is from the midline. The fascia is cut in the direction of the incision. The paraspinal muscles are separated from the spine, spinous process and the spine in the DEST endo technique, as we do in the open surgery. Whereas if you use other dilatation technique, the dilatation may be done through the muscles. So you can go through the muscle also in the different sets. So soft tissue overlying the lamina, the facet joint should be removed, and you should be able to see the superior lamina. So if you see the superior lamina, you see the facet joint laterally, and you see the superior portion of the lamina inferiorly or interlaminar window. So if you find a superior lamina, the facet joint and the interlaminar window, that means your localization was correct. So remove the soft tissue, and after that you go for resection of the bone. That means you remove the part of the superior lamina until you find the attachment of ligamentum flavum. So a significant portion of the superior lamina is removed, but only a small portion of the inferior lamina need to be removed. You can also remove the medial part of the facet joint so that it allows you the sufficient space to work. But people have used translaminar approach or even at L5S1 because the interlaminar window is quite large between the two lamina, superior lamina and inferior lamina. That interlaminar space is quite large, so sometimes without removal of the any lamina, you can get away and take out the lesion. So you can use either burrs, or you can use Carrison punch for removal of the bone. This is a small video, edited video of L45 disc. See, this is the last disc at L45. Patient had symptom on the left side, so left side mainly, and then it was also central. This is post-operative L45, good decompression, and the patient improved after surgery. So this is cranial, this is caudal, the medial and the lateral. This is L4 lamina, which is being nibbled using Carrison punch. So L4 lamina being removed until you find the attachment of the ligamentum flavum. And once you get the ligament of the attachment, then you try and separate the ligamentum flavum from the dura by pushing the patties in between the ligamentum flavum and the dura, and then remove part of the facet, and then dissect the disc from the root. So separate it, and then I don't push too much this root before removal of the disc fragment. It is very important. The root is already stressed, and if you further push it by patties or anything, by any retractor, it can give rise to persistent paresthesia after surgery. So I try to take out the some part of the disc before I try to retract the root, which is already stretched. So these are some of the fragment which we removed. So after the removal of the disc, then the facet decompression and further removal of the inferior lamina, just to make sure that the root is lax. So you can see that the ipsilateral root is quite lax. So that becomes the end of surgery, and in the end, one should also go for irrigation of the disc space. So if there is any loose fragment lying, that will be displaced, and in the end, then I just put in some Abgel, and I use dipomedrol so that the post-op pain is less, but it is controversial. Some people do not use, but I use dipomedrol. It gives good pain relief, at least for some time, 3-4 days, 5 days, and the patient has the confidence. The word about how to remove a central disc, and if there are multiple bilateral symptoms. So you have to go from the one side. This is a tubular retractor. This is a huge disc pressing the thecal sac which has been flattened. So how to remove it? You put in the tubular retractor, remove the ipsilateral disc, part of the disc is removed. You make some space in the disc so that the central disc also can be pushed inside the disc. It is difficult to remove that part of the disc. You can go over the top, but very, very difficult to remove this central disc and the opposite side disc. So best way for me is that I take out the part of the disc material there. I don't go for only targeted discectomy. So remove the disc and then push the disc fragment inside the disc cavity and take out from the ipsilateral side. And after the central disc has been pushed back in the disc space, then I push it with the right angle dissector, the opposite disc fragment also inside. So push these fragment inside and take out from the disc space. The ligamentum flavum hypertrophy and the osteophyte hypertrophy, you can go for over the top decompression. So if there is a compression from posterior side, that is hypertrophy of the ligamentum flavum, then you angulate your endoscope, which I'll discuss in the next slide. And you can also drill the osteophyte on the opposite side by the over the top technique. But if there is a central disc or even the disc on the opposite side, except the disc which has been extruded. So rest of the all disc should be pushed back in the disc cavity and take it out. Sorry. And by using this technique, you can find that at the end of surgery, your thecal sac will be well decompressed. So this is the technique. And if you have compression from posterior side, the canal stenosis, there is a osteophyte, there is a hypertrophy of the ligamentum flavum on the ipsilateral side and on the opposite side, and there may be hypertrophy of the opposite facet joint. So if it is there, then you can angulate your tubular retractor. You can go for undercutting of the lamina of the opposite side. But when you do this, you keep ligamentum flavum intact. When you do undercutting of the ligamentum flavum of the opposite lamina, there is a risk of injury to the dura. But if you keep the ligamentum flavum intact, there is no risk. The other trick which I use is that I don't remove the most innermost portion of the lamina. So when I remove the opposite lamina, I make a gutter, leaving a thin axle intact towards the ligamentum flavum and towards the dura. So I remove just part of the inner part of the opposite lamina, leaving some portion of the bone there. And this bone, I take it out with the Carrison thin, fine 1 millimeter Carrison punch. So keep drilling until you find the opposite side, even the facet joint. You can drill it, you can angulate it very nicely. This is the beauty of endoscope. And then in the end, you remove the ligamentum flavum. You will find that the whole thecal sac will bulge nicely, and there will be good decompression on. From posterior compression also you can decompress. So the advantage of endoscopy is that there's a better visualization. It is minimally invasive. It reduces hospital stay. There's a lower cost. It allows observer and the operating room staff to be more involved, and it is better for education because everybody can see what is being done. But there are limitations. There is a steep learning curve which you have to overcome. I mean, you have to learn the endoscopy, but it is not difficult. There may be some increased complication, especially in the initial learning curve. It is there when you learn any surgery. So more complication in the beginning. Therefore, it is better to choose simple case in the beginning and then progressively do more difficult cases. You may take little more time, that too in the learning curve only. But once you learn endoscopy very well, then the operating time is same as that of the microdiscectomy. And you might have to convert to the open surgery, that is microdiscectomy, especially in the learning curve. So these are the limitations. So don't hesitate to convert to the open surgery if you have difficulties. Regarding the results, you can see that this was the disc at L45, pre-operative, and the post-operative well decompressed thecal sac. This is compression on the right side. You see disc, and then after the decompression, the thecal sac has been decompressed very well. L45 level, good decompression. This was the compression. Patient had bilateral symptoms on both sides, legs, radiating pain, claudication. So L34 and L45 disc we removed using endoscope, and this was after surgery. Well decompressed thecal sac. The decompression has been done very well. So you can see the 3D image that you can remove both the lamina, and then you can undercut the opposite side lamina and even reach up to the facet joint and take it out if it is hypertrophied. Regarding surgery, the results, the surgery provide faster pain relief when we talk about only pain, but there may be pain and a neuro deficit. So definitely when there's a neuro deficit, it is far better than conservative treatment. But regarding the pain relief, surgery versus conservative treatment, surgery provides faster pain relief from acute attack than the conservative management. So at 1 year, the good outcome by surgery was 90% as against only at the end of 1 year. So you can imagine that the patient keep on suffering for a long period. So surgery provides early pain relief compared to conservative treatment. Therefore, it is indicated even for the pain. We are not talking about the neuro deficit where it is, I mean, there is no doubt that surgery is better. Even at 4 years, the surgery is slightly better. The results are better compared to conservative treatment, but this difference is not statistically significant. But at 10 years, the results are same of conservative and surgery for pain and not for neuro deficit. So that does not mean that surgery has no place, but that only means that most of the patients, they neglect their back after surgery and they develop the upper level disc or some osteophyte or facet hypertrophy. So the message is surgery is better for early pain relief and return to work, but you need to go for continuous care of your back after surgery in form of physiotherapy and good posture. So you have to tell your patient that I can treat your pain now by surgery, but you have to look after your back by doing proper posture and good physiotherapy after surgery. Otherwise, the other level disc may come back. The result of surgery is about 90% excellent or good outcome. But there is 7% there may be fair results or 3% even poor results according to modified McNabb criteria, which I'll not discuss because of the time limitations. The other techniques are transforaminal, which also has indications and quite good, but I don't practice. Microdiscectomy I was doing before. It's even quite good for some time, for cases, those people who want to, who do not know endoscopy can also do microdiscectomy. The results are almost same. But the opposite side visualization is not as good, and therefore the bilateral decompression, opposite side decompression may not be as good as you want. There is another new technique, unilateral biportal endoscopic spinal surgery, which also is quite good. The complications are there may be dural tear, pseudomeningocele, CSF leak, persistent paresthesias, which I'll discuss why it occurs. It usually occurs when there is a root retraction. So usually what happens is that we decompress, we remove the lamina, and then we see disc and we see a root, then we tend to retract the root. This should never ever be done. First, you, especially if the root is stretched quite significantly. So first, take out the, by small instrument or by, using the right angle dissector. So try and take out the prolapse disc and make the root relax. So rather than going for the root retraction, take out the disc fragment first and then you move the root. Otherwise, there may be persistent paresthesia after surgery. There may be infection, meningitis, and you can do wrong level, especially at L4-5 and L5-S1. If your tubular retractor is too much angulated, then you should be careful. You see, at L5-S1, by just slight movement, you can reach at both the levels. So by single incision, you can do L4-5 and L5-S1. So that means you can go for a wrong level surgery, especially when it is L4-5 or L5-S1. So regarding the complications, CSF leak is one of the major complications which may occur in certain percentage in the initial learning curve. It is more the causes of leak. This is more common when there is severe canal stenosis. So when you take a bite, you can also injure the dura. And this is more common when there is a large central or extruded disc, and if there is an inferior migrated disc, that means it will be pushing the thecal sac against the lamina and you can injure. The dura is pushed back and there is no protection. We all know that against the superior lamina, there is a ligamentum flavum up to the middle level of the lamina. So the superior lamina is protected by the ligamentum flavum, but the inferior lamina is not protected. The ligamentum flavum is attached only to the superior part of the lamina, and therefore, if it is an inferiorly migrated disc, then there are more chances that you might injure the dura because it is unprotected by the ligamentum flavum. And if you use wrongly the Carrison punch, if you want to take out the lamina of the superior part, use 90-degree lamina Carrison punch. But if you want to take out the lamina of the inferior lamina inferiorly, then it is better to use 90-degree Carrison punch to avoid taking the dura in that. And there is another thing which I will discuss, how to avoid the dural tear. the re-surgery also there is a risk because there is no ligamentum flavum, there is a scar tissue which is adherent to the dura, and if you try to separate the dura from the scar tissue, you cause dural tear. So it should be other way. You separate scar from the bone and not the dura from the scar. So remove little bit of more bone. So separate scar from the bone, lamina, rather than separating the dura from the scar. And when you are dealing with the opposite side pathology, then also you may catch the dura. So simple case selection in the beginning to avoid complication, keep ligamentum flavum intact until all the bone work is done. So what I do is I remove the ipsilateral lamina superior and the inferior. I drill the base of the ligamentum flavum and undercut the opposite side of the lamina. I don't remove ligamentum flavum until that period. So because it provides me protection for against the dural injury. So keep ligamentum flavum intact until you do the bony work. This is one thing. And when you use lamina, the Carrison punch for removal of the lamina, this is the lamina, this is the Carrison punch. So you take the bite. So you want to remove this part of the lamina, take the bite from the Carrison punch. But you have to be careful that in the bite there may be dura there. So take the bite, break the lamina, withdraw a little bit. So rather than taking a bite and in one go, you take out the bone. So take the bite and take out it. You might catch the dura and injure the dura. What should be done in rather is that you have broken the lamina, withdraw a little bit, so that even if you have taken the dura in that bite, it will be released, and catch it from the proximal part, rotate it, and then take it out. So not in a single jerk you remove the bone by the Carrison punch, take the bite, withdraw it, and then catch the broken part of the lamina and take it out. Regarding the drilling, it should be parallel or away from the dura rather than towards the dura. So you should be medial, lateral, or cranial caudal. Sorry, when you are drilling, or you go away from the dura rather than trying to drill towards the dura and causing injury. You can also use dura guard. It is available in some of the drills, or bone saver. So there are drills available or bone saver available where it can only take out the bone and will stop when you find the soft tissue. So bone saver prevents this thing. And I've already discussed that separate scar from the bone and not scar from the dura or from the root. And you go for axial drilling and use micro instrument to remove that portion. This is not seen. Anyway, so I think, okay. So the root injury or paresthesia, the causes are the root is pushed back by the ventrally placed disc. So this is the disc. It has pushed the root posteriorly. And if you either retract it or use Carrison punch, then you can injure this root. So this is a predisposing cause when there's a ventrally placed disc and pushing the root posteriorly, you may have post-op paresthesia. Or severe stenosis obviously can also, when you use Carrison punch or other things, can cause paresthesia. Recurrent cases, there is a fibrosis, you require more dissection and root mobilization. It can produce paresthesia or root injury, terminal stenosis, or stretching, retraction of the stressed root without disc removal. I have already discussed that if there is a disc protrusion, then you take out the disc first rather than retracting the root. So that should be done first. If you retract already stretched root, then there may be post-operative paresthesia, and there is a risk of injury when the disc migration is inferiorly because there is no ligamentum flavum there, and there may be paresthesia or root injury when there is thick ligamentum flavum. So this is the example. If there is a thick ligamentum flavum and very narrow canal is there, so you want to remove this ligamentum flavum, which at times is also along with the hypertrophy, this may be ossified. So if you try to come with the Carrison punch from medial side, where there are roots, the coda equina, and then it will further compromise. Already narrow compressed root will be further injured and the patient will have deficit. So rather than coming from the medial side and taking out the thickened ligamentum flavum, you come from inferior side or superior side and remove the thickened ligamentum flavum like this. So don't come from medial side, come from inferior or superior side, take out this and decompress the thecal sac. Incomplete decompression, because I mean, in the canal stenosis, it is not only the disc which is responsible, but there can be other things also. There may be a ligamentum flavum hypertrophy, there may be disc, there may be osteophyte, there may be facet hypertrophy. So everything which is the cause of problem should be addressed along with the disc. And I have already discussed that how to remove the central disc and the opposite side disc by using a right angle dissector, create a space in the disc, push it in the cavity and take it out. And if it is a ligamentum flavum or the osteophyte from posterior side, then you can angulate your tubular retractor and take it out, including the osteophyte coming from the facet joint. And so you should be able to diagnose what are all components responsible and go for complete decompression. People get confused that some people, especially in the Western world, they talk about targeted disc removal. So it is all right. It is good if the patient comes to you with a small disc. But when patient comes to you with a massive disc prolapse, which occurs in most of our cases because they try and avoid surgery. They are all scared because of the poor results. If somebody got surgery done in previous years, old age, I mean olden days. So there is in India there is a feeling that the results of spine surgery is bad. So therefore they come only when there's too much of neuro deficit, and then in that case you have to go for thorough decompression of the disc, then only, and the other component if these are there, because in long standing they have all these things: disc, the osteophyte, the ligamentum flavum hypertrophy also. There may be bleeding during surgery, and the most important cause of bleeding is the epidural venous plexus. So epidural venous plexus are there. If you have a huge disc prolapse, so proximal and distal to the disc prolapse, there will be angos vessels. So if you go at a wrong level, if you go above or below the prolapse disc space, there may be profuse bleeding. So you don't just, there is no worry. You have to think that you may be either above or below. Don't try to cauterize. Just place the patties there and the bleeding stops. And the other causes may be that the abdomen is not free. Patient may be there in the light plane of anesthesia, the vessel over the disc that need to be cauterized. There may be bleeding from the bone sometime. So bone wax, you use that bone wax. And if you use large incision, then the tamponade effect of the tubular retractor is gone. So there is some kind of oozing always occurs. So don't give larger incision. It is a disadvantage. The other complication is a hematoma, which may occur because of ooze from the epidural space or from the muscle. So when you finish your surgery, make sure that there is no oozing from the muscle or anywhere. The wrong level surgery also is possible, especially at L4-5 and L5-S1. So if your tubular retractor is too much angulated, see if it is angulated too much cranially or caudally, then I become very careful. If my assistant has placed the tubular retractor and he or she says that this is the disc, and if I don't find it 90 degree, I have a doubt. So too much angulation, you should be careful. And if your whole tubular retractor has gone down below the skin, it may happen in some of the obese patients, but if the whole tubular retractor has gone below the skin, then also you should be suspicious, because sometimes you may be in between the two transverse process and you might think that one transverse process above is the lamina above and the other one. So first orient that the structures on medial and lateral. So make sure that laterally there should be facet joint and medially this thing, the base of the spinous process, the lamina above and lamina below. And if your tubular retractor has gone too much down, then you should be, this has happened with me twice in the initial period, and therefore I am telling you. No overlapping, non-overlapping, so this the localizers, both the pins should be overlapping. If these are not overlapping, then you can imagine that the one limb may be higher up and the another may be lower down. So I mean, you might think that this is correct or this one is correct. So both limbs should be overlapping, and avoid excessive angulation. And if there is an angulation, I have told you that if too much of angulation is there, then you break the table and make your tubular retractor. I try to make it 90 degree. 10 or 15 degree angulation is all right, but excessive angulation I avoid, because if you angulate your tubular retractor too much, then the soft tissue try to come inside the tubular retractor and your surgery will become difficult. So another complication is more operating time. This may be there because of the frequent soiling of the lens by bone dust or the fluid. This may be overcome by intermittent irrigation in between the short period of drilling, and keep lens as much away as possible. Sorry. The another complication may be unstable spine. So this could be because of the wrong preoperative judgment about the instability. If you find that the bone back pain is out of proportion to the radicular pain, that should alert you, and then you should try to rule out the unstable spine by getting flexion extension X-rays. So I need water. Sarda, please water. Pani lab. And if you produce facet injury, then also if there is a foraminal disc or facet hypertrophy, then you should be careful. And if such cases are there, severe facet hypertrophy, in that case, you can go from the opposite side, or you have to be careful. Medial 1/3 facet removal is all right, but more than that you should not. So if there is a very severe facet hypertrophy, you can go from the opposite side. It is easier without removal of the facet from the opposite side rather than coming from the ipsilateral side. Paraspinal muscles, supra or interspinous ligament injury also can give rise to. So respect these ligaments and try to preserve them. And then conversion to open by the endoscope. If you are using endoscope, then sometime you might have to convert it to open surgery. This is another complication. So especially this may happen in learning your initial learning curve. So avoid unfavorable anatomy. So proper case selection, simple case in the beginning, avoid patient with a small interlaminar window, severe facet hypertrophy, thick and curved spinous process, because that will push your tubular retractor laterally, and this will be difficult to work on the ipsilateral side, which I have discussed in the beginning. There may be disorientation, so make sure that your camera head is towards the screen, and you must survey the anatomy first, identify the structures first by dezooming. You may be, so you should always identify the superior structure, inferior structure, medial and lateral. So to avoid that you may be there in between the two transverse process, and in between the surgery your camera may rotate, so make sure that those mistakes are not done. Inability to do proper biomanual dissection may not be there, so select proper case, proper diameter tubular retractor, and use slender instrument. If you use too much thick instrument, then there is hardly any space for you to manipulate instrument, and use triangulation rather than straight arrangement, and place endoscope at a correct position at the periphery, then it is not an issue. So proper learning of the technique, if you do it, then usually there is no problem, but in the beginning of your learning curve, you might face some of these. There may be excessive angulation, there may be bleeding, and massive dural tear with root prolapsing out. If it is there, then it is better to convert to open. Try to put it back, but if in the beginning of your surgery, if root prolapse occurs and you have not been able to remove the disc, then maybe in the beginning of your learning curve, you can convert to open. You can place the patties there, take out the disc, replace the root back, This is possible with the experience, but in the beginning, you can convert to open surgery, or you can go for inadequate decompression. If there's a massive disc prolapse and you remove targeted only a small portion of the disc, then your patient continue to complain problem post-operatively. Discitis, because of the more dead space, so avoid dead space, collection of the blood should be avoided, and there may be sterilization issue. Although the endoscope people advise autoclaving, but we avoid because of the cost issue. But I am aware that in European and American, you have to go for autoclaving of even these endoscopes and cameras. The other limitations are that there's a learning curve. There are more complications, and operating time may be more in the beginning of your learning curve. The transition from microscope to endoscope may be difficult because of the obstacle, various obstacles which are different. So there may be difficulty in identifying the structures because you see only part of the structures. So de-zoom and try to see, get the overview and control the bleeding. May be difficult. Blind area, unique skill is required for endoscope. 2D image, limited space, more operating time. And because of all these things, there may be more complications. So the best thing is simple case selection in the beginning, and then you move to the difficult case, practice on cadaver, watch videos and live surgeries, and take help of your colleague. You can take help of your orthopedics people or mentor in the learning curve. Visit our other department who are doing routine, the expert surgeon doing more surgeries, and you can use simulators in the beginning to learn endoscopy. So to conclude, the good case for the beginner are the spinous process are thin and straight. The base of the spinous process is not broad, good interlaminar window, horizontal lamina rather than vertical, paracentral disc, prolapse disc, not subligamentous. Subligamental disc also may be difficulty for the beginner. Absence of posterior dislocation. So avoid all these things which I have already discussed. So to summarize, the interlaminar approach is effective and safe in unilateral or in bilateral symptom, single or multiple level disc, highly migrated disc, lateral disc, central disc, extrafemoral disc also, recurrent disc also, calcified or fibrous disc, or the disc at all the levels, which may be difficult in the other technique, especially transfemoral L5S1 with the high iliac crest. The results are good, about 90% success, excellent to good results, but there's a learning curve and there may be more complications in the initial learning curve. For detail, you can refer to the chapter 24 in endoscopic surgery, a comprehensive approach, and some of our review articles, the endoscopic interlaminar disc removal and extent of decompression of the lumbar spine. So that also mentions how, you can decompress the thecal sac up to 200%. So even in canal stenosis, significant decompression can be done. So thank you very much. I thank my teachers. Thank you.
Thank you very much, sir, for an excellent and comprehensive talk, sir. Before I begin taking questions, I'll request panelists to give their comments and ask questions. We will begin with Professor Kodiswaran, sir. Kodiswaran,
Yes,
sir.
Dr. Yes, I'm here. Yadav sir, it was a wonderful presentation. Actually, the endoscopic era was started almost in spine surgery 2 decades back. Basically, it was started with Descendus procedure, then ECGO, then full endoscopic discectomies. In full endoscopic discectomies also, initially it was transforaminal. Now almost transforaminal is slowing down and interlaminar is taking up. So you also saying the most comfortable procedure is interlaminar approach. So what is your opinion about full endoscopic science surgery than our systems, Destando and ECGO?
I mean, full endoscopy means transforminal, you are talking.
Yes,
Or
sir. Transforaminal and
Yeah.
interlaminar both.
Yeah, so I think I have already discussed that interlaminar approach, you can, there is almost no limitations. I have not tried to compare the two approaches, but I have the, I think if the time permit, I can show the limitations of limitations of transformal approach and interlaminar approach, advantage and limitations are there. So in transformal approach, unless you are a very expert neurosurgeon, endoscopic surgeon using transformal approach, it is difficult to remove the posterior element compression. The angle at which you are going, I think I can use my, if I can share my screen again, then I have some of the presentation. Can you see this?
Yes,
Yes, sir.
So, I don't know. It is seen now.
what do you
Yes,
want
sir.
to see?
It's seen.
Okay, so I'll show that difference. Oh, sorry. There were some differences between transformal and when what are the various yes, this one. Sorry, in transformal approach, you see, in interlaminar approach, you can take out the disc, you can take out the base of the spinous process and opposite side. In transformal approach, see this one, you can take out the disc fragment here, but it is very difficult to remove the compression which is coming from posterior side. But now they have a curved instruments, and they say that they can drill the superior articular process, and therefore they can also do decompression, but it's again very difficult to go on the opposite side. So transformal approach has a limitation. There are studies which show that in lumbar canal stenosis, transformal is not as good as interlaminar. In interlaminar approach, you can go for 360-degree decompression. You can come from anterior side, you can go posterior to the thecal sac, so 360, except for situations where you have foraminal or extraforaminal disc. In that case, possibly transforaminal or is all right, or transforaminal is okay when you have even paracentral disc lying there, but if it is extruded or if it is migrated cranially or caudally, it is difficult for the beginner to do surgery. So I have a slide, which shows Interlaminar is minimally invasive. This is also minimally invasive. It is effective in all disc disease, interlaminar, but it's difficult at L5S1 transfemoral because the iliac process comes in your way, but there are again experts who go through the iliac process. So they drill hole in the iliac process and go. But for expert may be all right, but I'm talking about the beginner. High canal compromise or migrated disc, it is not suitable, whereas this is possible. But for recurrent disc, foraminal, extraforaminal, both are all right. Maybe transforaminal is still better. For lumbar canal or bilateral decompression, it is difficult for the beginner, but interlaminar you can effectively do it. Calcified disc, it's difficult, but I know now that they have a drill which can be passed through the working channel. So small drills are available now, and in future I think the innovations will limit the contraindication in future. So uncooperative patient and or anxious patient, because it is done, transfemoral is done under local anesthesia. In most by the most surgeon, but I am also aware that it is being done under sedation and under general anesthesia by someone, by few people, but it is a risky because the chances of damage to the nerve root are more. So if there is uncooperative patient or anxious patient, you cannot do transfemoral, and for neurosurgeon it is a familiar anatomy. No existing nerve root injury, but there is an existing nerve root injury may occur, especially if the pedicle is short and if the facet is hypertrophied. Symptomatic recurrences are more with the interlaminar, but less. There is a learning curve in both. So these were some of the difference, which because of lack of time, and I intentionally, I was not intending to describe the advantage and disadvantage of two approach. But
We have time. We have time, Dr. Yadav, if you need to go into that.
Okay. So I have described now the difference between these two, and I am also aware that uniportal, biportal, unilateral approach is also being done. It is also quite effective and safe, but the results are, these are coming out still. The long-term results are not available. Yes, Dr.
What is your
Kodi.
experience in redo cases, sir? Actually, failback syndrome.
Yes. So if you think that it is because of the either recurrence or inadequate surgery, it can be done very well. Now we are doing in recurrent cases, I do endoscopic surgery again. No problem.
But the difficulty of the scar
and
tissue will be there. No?
It is rather better because you can see things. So I've discussed it in the itself in the complication, that do not try to separate scar from the dura or the root. Never ever do it. So first you should take out little bit, either if you are using a Carrison punch, take out little bit of more lamina. So come from normal to the abnormal, and you find the cleavage. So take out little bit of more facet joint. So remove bone rather than trying to separate scar from the root or the thecal sac. So that is the key.
Yes, sir. Thank you.
Thank you, sir. I'll request Parihar sir to speak, please. Parihar, sir?
Hello.
Yes, sir.
Yes, we can hear.
I just want to know you still prefer this approach in Cauda equina, full blown Cauda equina.
Yes, always. I mean, for me, even bladder bowel involvement or anything, if there is a disc prolapse or canal stenosis, I always go for endoscopic surgery. No open or micro discectomy. Even for Cauda equina, I go endoscopic surgery. But again, I should say that I mean caution, because these patient will go to the other surgeon also, because they will continue to have the symptoms of bladder bowel involvement. So once they are not relieved, so they'll go to the different surgeons. And if you don't go for good decompression, therefore it is important to take out as much disc as possible and expand the thecal sac. So if you provide good expanded thecal sac, which is possible by endoscopic approach, as good as the microscopic surgery. So in presence of Cauda equina, I prefer now endoscopic surgery rather than the microscopic surgery, which is thought previously it was considered to be contraindication of endoscopic surgery. So previously people were thinking that bilateral symptoms, Cauda equina, all these things are not proper for endoscopic approach, but I do it all these cases. But I must say that this should be done after having some experience in the endoscopic surgery.
Thank you, sir. So I'll request Ratra sir to please comment.
Thank you, sir, for this comprehensive presentation of the lumbar disc surgery. But sir, my question is that how much disc should we remove? Only the disc causing the compression, or extruded disc, or how much disc should we remove?
Any bulging, what I do is that I take out the disc, which is ipsilateral side disc, and also I create little bit of space in the disc space, and then I push my thecal sac, I mean the disc back in this. So when you feel that the thecal sac is nice and full, then it is fine. But if I find that some tissue is coming with the angle dissector, when I want to go in between the thecal sac and the posterior longitudinal ligament. So if you try to insunate your right angle dissector, and if there is any resistance, I push it back, and then I take that fragment out.
And sir,
So in that process, it amounts to quite significant disc removal. When the disc bulge is significant, it is occupying 50% or more than that space. In that case, you have to remove most of the disc, not the only fragment which is protruding. So only when you remove the inside of the disc, then the protruded fragment can be pushed back in the disc space, and then you take it out. It is not possible otherwise. If you try to do that, then you will be retracting the thecal sac too much and causing paresthesia or increased neurodeficit.
okay, sir. Okay, sir. And one more question, sir. What are the tricks for the calcified disc, sir?
Calcified disc, I can use with the EasyGo, which I use. I can use Carrison punch to take out the disc. I can use drill to drill out that part. So this is possible, or you use, better safe is to use osteotome. So I use osteotome through the EasyGo, and with a hammer and osteotome, I break that calcified portion and take it out.
Thank you, sir.
Sir, we have with us Professor Harshad Parekh, sir, senior faculty from Mumbai. I request him to ask and comment.
Sir,
Good evening, sir.
Sir.
Yadav, sir, you are master of endoscope now. You are showing one by one every Sunday some new techniques coming. I totally agree with you. Interlaminar can give you the best view, 360-degree, to remove the spinal canal stenosis, disc, root decompression, and even you can do a stabilization single level. There is no problem about that. And transforaminal approach is only very helpful if there is an extreme lateral herniation of a disc or disc which is little migrated out of the foramen or in the foramen. But otherwise, its central disc and all the peripheral disc is not going to work. So interlaminar will give you a good decompression and it gives you a very good view. And the chances of leaving the disc behind is also less. I have learned and I've been trained to do a full discectomy right from the day one we started learning. And I've still not understood the concept of targeted disc. I feel yes, we remove the disc fully. Otherwise, in my experience of so many years, they come back with some other same place. Some small fragment has come out and
Yes, you are right,
they
sir.
come back. So
You
I
are-
curate it out completely there, whether I fuse it or I don't fuse it, I do it completely. And yes, endoscope gives you a beautiful light inside. And the another advantage of endoscope, probably which your list didn't mention, is that the retraction of a dura and the root is much less than the microscopic. This is my personal view on that. We do not retract the root too much because endoscope gives you good light. There's no worries, and that is one more advantage. One more thing: epidural veins. I try and not to coagulate as far as possible. They are good veins and they have some blood supply to the, means they carry the blood back from the nerve root. And if you coagulate those veins, patient has got some kind of paresthesia persistently postoperatively apart from handling. So I always avoid, and most of the time the veins are distended because of the position, abdominal compression, rather than anything, unless the disc is too large. When the disc is too large, they don't compress, they stretch the veins. So it may be becoming easier to do. And wonderful technique. And most of the time, we don't have to go to the other side by, if you remove the disc from the same side, complete disc removal. So I feel interlaminar approach is really good approach, and it is like a replacement of a microscope by the endoscope. Same thing what you do in microscope, you're doing with the endoscope. So interlaminar really works very well rather than any other techniques which we are seeing or maybe experiencing. And slowly people will realize more and more with the long-term results, as you have very clearly said. So what happens when patient comes back? The worst thing is that patient in our setup, the patient keeps on coming back with the back pain. You remove part of a disc and we realize that the root is not decompressed well or something is happening. MRI also doesn't it gives you a lot of picture. Okay, there is some fibrosis is occurring. So all these things can be avoided if you are doing a proper interlaminar way. You feel you are doing as if you are doing a microsurgery. This is my experience about that. Redo surgeries. I have done plenty of redo, and I have experienced everything, root injuries and dural tear. One thing is very certain, I will always do the scar removal from the roots and decompress the roots completely. I do get a plane of cleavage. Eventually, we do the same way. You go laterally, start from a normal and find out. And unless we remove the scar, the patient doesn't come back, patient doesn't improve. This is my experience. Maybe everybody may not agree, but I have always removed the scar. Yeah, occasionally we do get tear of the dura when you are removing the scar. So this is another point which I have experienced, and I feel that I also use always Lepamidrol post-operatively. It helps in two ways. One, you said very clearly, is the pain relief, and second is that it
Inflammation.
prevents the adhesions. The
Inflammation.
fibrosis around definitely reduces. You know, people in older days, people used to put a fat there, soaked in a dexamethasone, and put a fat there. So these were the reasons why they were doing it in those days. So wonderful technique, an excellent way of presenting, and you given a very elaborate endoscopic removal of a disc and decompression. Thank you.
Thank you, sir, for your comments. Thank you very much. Excellent. I agree with you.
Thank you. Thank you.
Thank you, sir. Thank you, sir.
Uh,
There are some questions.
Only for there may be some confusion for beginner about targeted disc removal and the whole disc removal. See, if you have unilateral symptoms and small disc prolapse unilateral, then it is fine. Targeted, you remove that part and forget about. But if there is a central disc prolapse, use disc prolapse bilateral symptoms, which some of you may not be doing, but I do all these cases endoscopic surgery. So in that case, it is important, as sir has already said, Dr. Parekh, that you remove as much disc as possible. But I remove only that portion and do not remove the whole disc. So create a cavity, push the fragment back, and if I find the legs thecal sac, that is the end of my surgery. Yes.
Thank you. Thank you, sir. So there are, if you permit, we can take questions now.
Yes, please.
Sir, there's a question. Dr. Lal Rahman has appreciated your talk, and he's asking what can be done when there is a dural tear during the procedure.
Yes, if there is a small dural tear, you just continue your surgery and just keep patty there on the tear and remove the disc fragment, and a small dural tear does not require anything. You just can put in Abgel or fat. If the dural tear is little larger, in that case, you can use fat or some dural substitute along with the sealant tissue glue. So this works very well, and because the dead space is not there, so therefore the post-operative CSF leak issue is not a problem. If I get a dural tear, and in that case, I go for delayed suture removal. Without any dural tear, I don't apply any skin stitch. But if there is a dural tear, what I make sure that I obliterate all the dead space and I apply skin stitch and delayed suture removal. It works very well. If there is a dural tear with root prolapse, in the beginning of your learning curve, it is better to abandon the endoscopy and come with the microscope. Or what you can do is you just place the patty there on the root and remove go for decompression. Once you decompress, then you can put the root back. Don't try to put the root back when there's a huge disc prolapse and you have produced a dural tear, the root is protruding. Now I have done some surgery that I had, not some, but 3-4 times I have come across, there was a root dural tear and the root prolapse in the beginning. So I continue with the surgery, decompress the disc. And once you decompress it, then you can put back that the prolapse root, and then you put the fat and the dural substitute and it works. Don't try to replace it when the disc has not been removed. Yeah.
Thank you, sir. I'll also request other participants to also type their questions. Meanwhile, I'll ask, Dr. Deepak Baria has asked, sir, please share or show the video starting from skin incision to inserting of the endoscope. Thank you. I mean, you can,
I mean,
tell the steps.
right now, I think I don't have that video, full video, because all videos are edited videos. We'll try to share after some time, but I think I have shown the skin incision. When same, it is 1 centimeter away from midline. Then in tubular retractor, you can either separate the muscle from the spinous process as you do in the microsurgery, or you go through the tube. There are dilators available, so that I have, because of the lack of time, and also I don't have a full video. I mean, I can show others also video, but unfortunately, the unedited full video is not available with me right now. I am sorry. Sorry.
Thank you, sir. Thank you. Sir, for juniors, I'll be asking, sir, please give ideas for future research on these topics.
So that Jitin will give ideas. I think a lot of things maybe in the future surgery may not be required. So please, Jitin, you tell, because I don't know much.
No,
Please.
I was thinking whether we can combine stabilization along with this. I mean, after discectomy.
Yes, yes, that can be done.
Percutaneous.
That
Yes.
can be done.
So
That
that
can be done.
contraindication. Yes.
I mean, you decompress and then you can go for percutaneous fixation also is possible with interlaminar, and also with the transfemoral also they are doing. So it is possible. Yeah, decompression and fusion, both stabilization can be done. I was thinking that you are asking me some hi-fi things of
No, actually, according to innovation aspect, the cost of these equipments are very high, sir. So what I tried in my initial days, I used to buy multiple sizes of proctoscope, from pediatric proctoscope to adult proctoscope. So I used to use them as dilators. So it will be around 50 rupees to 100 rupees. The entire dilator set will come around maximum of 1,500 rupees. We can use, if you start from pediatric proctoscope, you can have the handle. So one person can hold that. Once you go inside the muscle, it will fix in the bone. Slowly, you can increase the size of proctoscope and remove the smaller one. So at the end, you can insert the bigger one and keep it as a easy go. So local made easy go. So you can use your normal instruments, and the only problem is you have to have a scope holder. So these kind of innovations can be done in this area.
Yes, absolutely, because cost is a concern. We may talk anything, but I know I struggled throughout my life in procuring instruments. So this is a concern for low income group countries and even middle income group countries. We have to say that there are places in the periphery where they don't have this facility. And I'm sure that the main cause of the people not doing too much of endoscopic surgery is because they don't have the equipment available, which are very costly. So I think something need to be done, which is quite possible, but the government has to help. It is possible. These are all simple things, but are sold at very high cost, unnecessary. But they have to do it because there are so many infrastructures, so many manpowers they are hiring. And unfortunately, for any new things to bring in the market in Europe and in America, it costs a lot for the companies. So they are also not completely wrong. This is beyond discussion, but I think we need to have something. The simple things can be made very inexpensive. Yes.
Thank you, sir. Thank you. I'll request all attendees, if anyone wants to ask, you can please feel free. So, sir, that was a very excellent talk and very fruitful discussion between the panelists. Thank you very much. So,
Okay, very good. Yeah, very good, Jitin. Thank you for maneuvering through all the questions and involving other people. And Dr. Yadav, thank you taking the time for another great interactive session. I'm sure a lot of residents benefited by the wisdom being passed around. And we look forward to seeing you next week at the same time for number 10 of the series. What's the series number 10? What's the topic here? Let me see here.
pituitary on pituitary.
Pituitary. Yeah.
Endoscopic trianguloid. I can't read it. My eyes aren't that good. But anyway, we look forward to the next week's session. And thanks all the panelists for participating and making it even a lively discussion. So, okay, thank you. Stick around.
Thank you.